So metal allergies, fact or fiction? For the 6 people in here, do you think it's real?
Yes.
Yeah? All right. So it does seem to be a fact, but it's rare, and we have absolutely no evidence-based guidelines for this. So this is a little busy, but I'm just going to make a few points here. So first, the way that this happens is you get corrosion and you get metal ions, and it leads to a type 4 hypersensitivity reaction. And what do I mean by that? It's not like a peanut allergy, which is a type 1 where you get it instantaneously. This is delayed. Now, you have to have metal ions be created by trinunosis or other ways. So it may happen in a couple weeks, couple months, we don't really know. The second point to make is these metal ions mate with proteins, make haptens, and they have to be presented to the immune system by an antigen-presenting cell. In the skin, it's a Langerhans cell. There are no Langerhans cells in a joint. In fact, it's unknown what the APC is, antigen-presenting cell is in a joint. So it's really, truly unknown if this happens in a joint. What we do know is there's truly cutaneous manifestations of metal allergies, but we really cannot prove that it occurs intra-articularly. So what are some observations? So there's a lot of case reports of cutaneous manifestations after total knees of implants that are being put in. They typically get better with local treatment, steroids, but the reason we think this is really related to metal is there's a number of case reports that when you remove the implant, it actually gets better almost instantaneously. There is a case report by Brad Parsons of a dislocated shoulder that they had, which led to a lot of metallosis and actual cutaneous manifestations of the metal. So it does seem to be real, but a couple of observations that make this a little bit strange is it's much more prevalent in total knees than total hips, and we don't know about total shoulders. So there may be something about it being superficial, or knees being much more superficial than hips or shoulders. We also know that testing is not predictive. We don't have a gold standard. We can't really define whether this is real or happening in a joint, so you can't test sensitivity and specificity for any test. And then we do know that skin sensitivity to nickel, cobalt, or cement is much more than likely implant sensitivity. So about 20% of the population has a sensitivity to nickel on the skin, and certainly we don't see 20% of the population having pain to the implant. So there's something going on that we don't quite understand. Now, there is no gold standard test, but skin patch testing is considered by most sort of experts to be the go-to thing to do. But it's qualitative. We don't have a known sensitivity or specificity without a gold standard, but it is accessible. There's a lymphocytic transformation test, which seems objective because you take your peripheral blood and you basically challenge it with metal salts, and you can quantify the lymphocytic reaction. So people like that, but again, unknown sensitivity or specificity. It costs a ridiculous amount of money and limited availability. So if you had to do it, and we'll get into an algorithm of what to do in a moment, in total hips, total knees, they have cobalt chromium coated implants, so zirconium or oxidized zirconium, which is called oxinium. Other things you can do is ceramic in the hip, which has essentially gotten rid of this issue, or an all-poly tibial component. For total shoulders and RSAs, we have titanium heads and glenosphere, which have terrible wear patterns. The reason they don't use them in the hips is because they literally wear down, and they cost a lot of money. I recently put one in, and it costs about $17,000, and a typical reverse costs about $5,000 in my hospital. So it's very, very expensive. They do have, FX and Medacta have this titanium nitrate coated shoulder, which is not FDA approved for this indication, but it would work for this indication. And it's gold, which is really cool. If you look at the shoulder literature, it is very consistent with other literature. 20% of the population is sensitive on their skin, predominantly female. But what's really interesting, this came from the Mayo Clinic, is they retrospectively looked at patients who had positive tests. And 88% of these patients were satisfied, and the 12% had actual mechanical reasons to not be satisfied. So there's a lot of false positives. So what's an algorithm? It's sort of don't ask, don't tell. If you tested everybody, you'd have 20% needing this to be put in. So if they truly have a history that they tell you, if it's mild, ignore it. If it's severe or they insist on it, get a test. If the test is positive, use a hypoallergenic implant. So in summary, metal hypersensitivity to implants is real. mainly cutaneous. No evidence-based guidelines for testing. Patch testing is okay, lymphocytic transformation testing as well, but it's not validated. Testing in hypoallergenic implants for severe skin reactions and a positive test. Thank you.